Hi, everyone. My name is Jonathan Samet from Lurie Children's Hospital in Chicago, Northwestern University. And I'll be giving this talk on pediatric elbow fractures for the SSR Lecture Bite series. I'll be reviewing the pediatric elbow anatomy and a few of the most common fractures. Elbow anatomy in pediatrics is a tricky area because there are numerous ossification centers. The mnemonic CRI-TO is helpful to remind us of the order of ossification centers. The capitellum appears at 1 year, then the radial head at 3 years, the internal epicondyle or medial epicondyle at 5 years, trochlea at 7 years, olecranon at 9 years, and external epicondyle or lateral epicondyle at 11 years. The trochlear ossification center commonly appears in multiple small little nodules of ossification. That's normal. And the olecranon as well can have secondary ossification centers. The radial head and the capitellum should be aligned on all views. This is one of my things on my checklist to make sure that I don't miss a radial head dislocation or subluxation. The anterior humeral line runs along the anterior cortex of the humerus and should intersect the middle third of the capitellum. This can be useful when trying to detect subtle supracondylar fractures with posterior angulation. First, when looking at an elbow in the setting of trauma, we want to be able to identify a joint effusion. Normally, we only see the anterior fat pad as a thin sliver of lucency anterior to the humerus. We don't see the posterior fat pad. In the setting of an effusion, the anterior and posterior fat pads are splayed outwards away from the joint, and they're lifted, and therefore you see the posterior fat pad as well as the anterior fat pad shown here. The most common elbow fractures we see are supracondylar, lateral condyle, and medial epicondyle. Supracondylar fractures are mostly hyperextension type, and therefore, when looking at a lateral film, the capitellum is going to move in the posterior direction relative to that anterior humeral line. And in fact, if the anterior humeral line is completely anterior to the capitellum, then that is often a deciding factor for orthopedists when determining if a patient needs surgery. If it is non-displaced, then these can be treated with casting. Sometimes on the AP view, you'll see a transverse fracture line, but often you may not. And this is an example of a significantly displaced supracondylar fracture where the anterior humeral line is clearly anterior to the capitellum. Lateral condyle fractures can be a Salter-Harris 2 or a Salter-Harris 4. These are tricky fractures because the fracture can involve the metaphysis to the growth plate, but it may also extend into this invisible area of unossified epiphysis and into the joint, making it a Salter 4 in some cases. So we have to remember that there's the physis for the distal humerus, and then here is the joint line, which is invisible. In this patient who happened to get an MRI, which is not standard the case, you can see here that there is a fracture line going through the metaphysis into the growth plate, but then continues into the unossified trochlea and then into the joint space. And in this case, being a Salter-Harris 4. We typically measure the largest gap, and if it's over 2 millimeters, then that might be an indication for surgery. Medial epicondyle fracture is an avulsion of the medial epicondyle apophysis from the humerus. In this patient, where we compare to the normal contralateral side, you can see that the medial epicondyle is displaced off the humerus. Remember, the common flexor tendons attach to the medial epicondyle and they exert a strong pull. Treatment is often non-operative, but may need surgery if it is displaced or entrapped in the elbow joint. In this case, you can see that there was a trauma denoted by the soft tissue swelling of the medial elbow. This is where the practical use of the CRI-TO mnemonic comes in. If we look at the ossification centers, we might say we see the capitellum, the radius, but when we get to the eye or the internal epicondyle, we're confused. Where is it? We don't have the eye, but we do have the T as the trochlea. And we also have the lateral epicondyle. This is when the cryotonomonic will alert us that we should be seeing the medial epicondyle. When we look more closely, we see the medial epicondyle was avulsed inferiorly all the way into the joint. And this is a very important finding to recognize, as it might indicate that the surgeon needs to operate to release this epicondyle from the entrapped joint. So I'd like to thank you for listening to this short talk on pediatric elbow fractures. Please email me if you have any questions. Thank you so much.